Okay, everybody, welcome to today's session. I thought if you can unmute your phones, what we'll do today is have a pop quiz, not to put you on the spot, but I'd like you to just go around the number of people here and each person take something in sequence. So let's go to the first case. Rowan, do you want to take this one?
Sure. So it's a 58-year-old male vomiting. We got little mild hyponatremia, hypokalemia, hypochloremia. Um, and then
And focus just
yeah,
just
and
just
I
on.
gotta look there. And then the acid base status. So your pH is on the high side, presumably. I guess we don't know ABG or SPBG. The total CO2 is a little bit on the high side, and the bicarbonate in this is also relatively normal. So it sounds like somebody who's this looks like somebody who's got maybe a contraction alkalosis from vomiting.
Okay, so remember, when you look at these things, you have to go in a very sort of linear fashion, as alluding to in previous talks. You focus first on the bicarbonate, and in your mind, answer the question: is it normal, elevated, or decreased? Try to rid all previous approaches, because you just are not going to get through the boards quickly enough on these questions. And typically, the fellows don't do great on these questions when we look at questions throughout the fellowship or are on the boards. This is one of the hardest categories. So unfortunately, it just takes a memorized approach, which we've been going over the last number of months. So the first thing you look at, if the question is what's the acid-base diagnosis, is that bicarbonate. Don't look at anything else. Don't look at the pH, don't look at the PCO2, and don't look at the total CO2. Look at the bicarbonate, and it doesn't matter if it's a VBG or ABG, the bicarbonates are roughly the same. So in this particular case, is the bicarbonate normal, elevated, or decreased?
This is a little bit elevated right now.
Yeah, I would say it's very elevated.
Yeah.
The normal bicarbonate in a male is 25. You'll never see
Yeah.
anything over 26. So it's actually significantly elevated. So if you have an elevated
Okay,
bicarbonate,
can I go now?
the next thought is, what are the three? And there's only three. There's three in the elevated and there's three in the down direction. So if it's elevated, what are the three acid-base disorders that elevate the bicarbonate? One is a metabolic alkalosis, and the other two are acute or chronic respiratory acidosis. That's it. Those are the only three things that could cause the bicarb to go this high. So the task then is, after identifying the three, to distinguish between the three. And the approach then is to next look at the PCO2. We never look at the pH. You do not need to look at the pH to diagnose acid-base disorders for the rest of your career. So you look at the PCO2, and how does that help you? Well, the next technique or the next thought is you have to look at the change in the bicarbonate from the original value, and you don't have it here, but we'll assume it's 25, which would be the average in males. If you look at the entire male population, the average is around 25. And then you ask yourself, how much has it changed from 25? And that's called the delta bicarbonate. So you calculate first the delta bicarbonate, and the next thing you do is you calculate the delta PCO2. And again, it's the same thinking. We don't know the original PCO2, so we'll assume it's 40, which would be the average of a group of males in a large population. And the delta here is 7. So the next thought is, what acid-base disorder has a change in bicarb to change in PCO2 of roughly 7 to 10? So the delta PCO2 is 7, the bicarb is, or you can say 3.5 to 5, but the ratio is 7/10. And it's one of those three. If it's one of those, if it's a simple disorder. So if it's the question is, which disorder has that a ratio of the change in PCO2 to bicarbonate of the three we mentioned? And we're only mentioning three because there's only three that raise the bicarbonate. And there's only one. It's metabolic alkalosis that's compensated. So in anyone who is vomiting or who's on Lasix or has Bartter syndrome or Gittleman syndrome, whatever the cause of the metabolic alkalosis, for every change in the bicarb, the PCO2 goes up by 0.7 of that. And that's a universal rule. And that allows you, because it's so universal, to immediately say this is a compensated metabolic alkalosis, and it cannot be acute or chronic respiratory acidosis, because those have different deltas, which unfortunately you have to memorize also. And there's 6 acid-base rules. So this patient has a metabolic alkalosis, and it's because the delta bicarb to delta PCO2 for the elevated bicarbonate is 10⁷, or you can flip the numerator and denominator, it doesn't matter. Okay, so let's go to the next case. And Hassan, do you want to, oh, sorry, before getting into that, when you have a metabolic alkalosis, this is now not talking about the diagnosis per se, but what are the so-called phases or physiologic processes that lead to this? And there's always 2. So if they ask you on your exam, how do you get the metabolic alkalosis? Your brain immediately has to think of 2 things. One is, where did the bicarb come from? And that's called the generation phase. And then the second question is, why is it not being excreted by the kidney? Because generating bicarbonate is not sufficient for having an elevated bicarbonate in the steady state. Something else has to happen. And what has to happen is you have to have a so-called maintenance phase, or saying it a different way, the inability of the kidney to get rid of the bicarbonate. So your brain has to think of, where's the load coming from, the generation phase, and why is the kidney not excreting it? And that's true for every cause of metabolic alkalosis. So in this particular case, it's the stomach which is the source. So the gastric vein has become a bicarbonate IV when you vomit, and it's just pumping in a ton more bicarbonate into the IVC than normally occurs. Now, normally the parietal cells in the stomach have this is the transport architecture of the cell. There's an HK ATPase which acidifies our stomach, and every time a proton is secreted, 1 bicarbonate ion is generated, and that bicarbonate ion does not stay in the cell, number 1, nor does it go into the lumen with the proton. It actually is vectorially transported on the other membrane on a protein called AE2, which stands for anion exchanger 2, into the gastric venous blood. And this occurs normally when we eat. That's the so-called alkaline tide. Normally when we eat, the gastric vein pumps more bicarbonate into the IVC, but it's transient. With vomiting, excessive vomiting, first of all, it can last longer, and also this whole process quantitatively is significantly increased. So the magnitude of the bicarbonate that's entering the gastric vein is much greater. So the same process that occurs normally is exacerbated in vomiting, and that's the source of the bicarbonate. It doesn't come from any other part of the body. We basically have a gastric venous bicarbonate IV. Okay, but that, again, just like if you started a bicarbonate IV and did nothing else, the kidney would just pee it out. It would recognize the excess bicarbonate load, and it would all end up in your urine. Your blood bicarbonate would not increase. So it's very interesting that this load is not excreted. And it's not excreted because the vomiting also affects the kidney, not because it affects the kidney's ability to generate new bicarbonate. That's occurring in the parietal cells, but it prevents the kidney from getting rid of bicarbonate by affecting 3 sites. And they could ask you this on your exam. The first is the glomerulus. For a given concentration of bicarbonate in the blood, we have prerenal failure, which means our GFR is decreased, which means the magnitude of bicarbonate coming into the proximal tubule is decreased below normal. And that's going to be the first site that decreases the kidney's ability to dump bicarbonate in the urine. There's just less bicarbonate coming through all the into all the proximal tubules to begin with because of the volume depletion. The second thing is for every given amount of bicarbonate that does get into the proximal tubule, the proximal tubule for that load is absorbing more. And that's because angiotensin 2 goes up, which stimulates bicarbonate transport. It also increases because the sympathetic nervous system affects proximal tubule bicarbonate transport. But the bottom line is for every given load, and the load is decreased, but of that load, even more of that is absorbed back into the renal vein. And then the third side is not an absorption issue, but remember, we always secrete some bicarbonate into the urine. It isn't just absorbed. Bicarbonate secretion occurs, and that was discussed in the acid-base talk given by Dr. Soleimani a few weeks ago. There's a protein called pendrin in the cortical collecting duct that actually secretes bicarbonate. And if that secretion is decreased, it'll also be a reason for getting less bicarbonate in the urine and not being able to dump the bicarbonate for a given bicarbonate load. So there's three concepts here. One is there's less bicarbonate coming through all the filters in our kidneys, less bicarbonate coming through the glomeruli, less excreted. Of that load, more is absorbed. That's the proximal tubule. And pendrin cannot secrete bicarbonate normally. And that has to do with the fact that it's a chloride bicarbonate exchanger. And with less chloride coming into the lumen here, there's less bicarbonate secretion. That's why, for example, giving chloride IV ameliorates the metabolic alkalosis. It has nothing to do with volume when pendrin is doing it. It has nothing to do with the proximal tubule. If you don't give chloride, you can still volume replete a patient. I can give you sodium gluconate and your blood volume will increase. I'll get rid of your prerenal failure, but you still will have problems correcting the metabolic alkalosis because you've got to get chloride into the collecting duct here to turn pendrin on. And that they could ask you that on your exam. Why is metabolic alkalosis chloride dependent? Or why does giving saline correct the metabolic alkalosis? Most people say, oh, it just, you're giving volume, you're getting rid of the so-called contraction alkalosis, which is not a great term, by the way. We'll talk about that another time. There is an effect of volume repletion, but the major effect is you're enhancing the chloride concentration by giving sodium chloride and stimulating pendrin to dump bicarbonate into the urine. Okay. Hassan, do you want to take this one? Can you unmute? Can I ask someone else to unmute and take this one? Hassan, can you hear me?
Hey, Dr. Kurtz, I can read it out. So it's a 28-year-old female presenting with.
Sorry. I thought you were somebody else.
Oh no, I don't know. I don't know if Hassan might be on the
Okay.
line as well. This is a Porva, by the way. Sorry.
Yeah, I can see now. Sorry.
Oh.
Or it wasn't showing the names.
Oh yeah, no problem. So this is a 28-year-old female presenting with diarrhea, and has an NG tube. So the labs show hyponatremia, pretty severe hypokalemia, azotemia, a high BUN to creatinine ratio. And then as far as the acid base status, it would appear, well, I guess the total CO2 is a bit low, but the pH is normal.
No, the total CO2 is 25. It's normal.
Oh, I'm sorry. Total CO2 is normal. The PCO2 on the blood gas is, I guess, low normal.
Well, remember, it's a female. That's normal for a female.
Okay.
Remember that difference on your exam between males and females. Females do not have a PCO2 of 40.
Yeah.
Do a population, and that's important because when you're doing your deltas, if you use 40 for female, you're going to make a mistake. And the bicarbonate is at the most 24, usually 23, 24, but you just don't see 25, 26. And it sounds like a subtlety, but when you're looking for subtleties, you can make a mistake. So the bottom line is these numbers are normal, but
Yeah.
continue on.
Yeah, I mean, just guess from the clinical history of the diarrhea, you're losing bicarbonate for your stool, so you're probably going to have a metabolic acidosis, and then a non. That would be my guess, although that would be more slow
Yes,
bicarbonate.
what you say is correct. You have normality here, and you don't really have many clues. Sometimes you'll see an elevated anion gap, and then you know you're dealing with more than one acid-base disorder if the numbers are normal. Otherwise, how could you have an elevated anion gap with normal numbers? It can't just be an anion gap metabolic acidosis. But here, you don't really have any clue from the numbers other than you've got, you know, the sodium of 130, potassium. You're seeing some things are going on here, and yet you've got this what appears to be paradoxical normality with the numbers. And you know, one of the options that they're going to give you a question like this, and one of the options is going to be no acid-base disturbance. Now, that's sort of conceptually complicated because you have to parse that. Yes, the chemistry is normal. So you don't have an acid, what we call an acidemia or alkalemia, the emia meaning that there actually is, from the snapshot, a change in the proton concentration or bicarbonate concentration or the PCO2 in the blood. All these numbers are normal. But remember, for the rest of your career, that does not exclude an OSIS, metabolic acidosis or alkalosis or respiratory. OSIS is a process. It doesn't tell you what the net result will be. So for the rest of your careers, distinguish emia from OSIS. So there's no emia here. There's no abnormality in the acid-base numbers, but that does not equate to the lack of an OSIS, which means the lack of a process which would tend to elevate or decrease these acid-base numbers. So you still have to be curious to think further and not just write normal acid-base status. So yes, the diarrhea and the NG suction should immediately make your mind think of, well, maybe there are acid-base disorders here. Maybe there are OCs. You mentioned diarrhea. Yes, that would cause a non-gap metabolic acidosis. But then the question is, why is the pH, PCO2, and bicarbonate normal? Well, either you don't have diarrhea that's of great enough magnitude to alter the numbers. That's possible. But on an exam question, they're not going to put diarrhea and give you normal numbers. So you have to think further, and there's another clue. There's NG suction here. And NG suction leads to what?
So that would lead to loss of protons.
Right. So what acid-base disorder does that cause?
Metabolic alkalosis.
Yes,
metabolic,
so it would cause a metabolic alkalosis. So you have two, as far as cause and effect, you have clues here that should lead to two acid-base disorders, but they're opposite in direction. So then you have to think, well, if that's the case, maybe that's why these numbers are normal. And that's indeed what's going on here. You have a non-gap metabolic acidosis and a metabolic alkalosis, which must be what quantitatively? Are they equal in magnitude, or is one greater than the other? Go ahead.
They must be fairly equal, right? For you to have,
Yes. So that's sort of the major teaching point here, that from the diarrhea and NG suction, and they wouldn't give you this unless they were of great enough magnitude, they must be causing, at least on your exam, they don't have to in the real world, OCs, but one is going to tend to raise the bicarbonate. Remember, we only look at the bicarbonate when we're thinking about these things. And the other is going to lower the bicarbonate. And the fact that we have normal numbers here, let's first talk about the bicarbonate. The fact that the bicarbonate's normal must mean that these things are equal in magnitude. The loss of the bicarbonate from the NG site, or the bicarbonate generation, excuse me, the bicarbonate IV going into the gastric vein is quantitatively equal to the bicarbonate loss that's occurring from, usually it's small bowel diarrhea that leads to a non-GAP metabolic acidosis. Remember, large bowel diarrhea causes a metabolic alkalosis. Remember that. Okay, there are congenital abnormalities, chloride losing states, but that's a large bowel issue. Remember that. You can actually distinguish where the diarrhea is coming from by the acid-base disorder. But it means that the loss of bicarbonate in the stool from the small intestine is quantitatively equal to the bicarb being added through the gastric vein. That's what all these numbers tell you without doing anything. It has to be that, or you would not end up with a normal bicarbonate. Recognize again, we're dealing with a female. That is normal. If the bicarb's normal, there's no reason the ventilation should change. So the PCO2 should be normal, unless this person also has a disorder of ventilation, which would be either high or low, and we'd add to what's going on here a respiratory acid-base disorder. But in lieu of any lung or brain abnormality, there's no reason the person shouldn't be ventilating normally when the bicarb's normal. And of course, if the PCO2 and bicarb are normal, according to the Henderson-Hasselbalch equation, the pH must be this exact number. In fact, without the that's why I say forget the pH for another reason, and that is these numbers are mathematically interrelated by the Henderson-Hasselbalch equation. So if you know the bicarb and you know the PCO2, the pH must be 7.41, even without the blood gas machine measuring it with a pH electrode. They could ask you that on an exam. They give you the PCO2 and bicarb and say, what's the pH? You need to be able to calculate it. So measuring it doesn't give you any additional information. You already know that just from these two numbers. Okay, so this patient has, as we said, a non-anion gap metabolic. This is what you would put on the exam. You'd put these two things, and they must be of equal magnitude. Okay. Someone else unmute or? Okay, Ramon, doing well. Why don't you take this one? Don't be afraid to stick your neck out.
You just proved me, Dr. Kurtz. Once
wall.
you said something positive, I'm totally gonna say.
No, I'm just saying you only get through these things when you're tossed into the water.
It's fair enough. All right, I'm gonna start.
Don't worry about whatever you say is fine.
I'm gonna start bottom up. So the bicarbonate is low.
Very good. That's excellent. Forget all the rest. At least for this analysis, the bicarb's low, so it's again one of three things, and it's. Do you have an idea what those three could be? Three acid-base disorders that you now have to distinguish.
So it can be a metabolic acidosis.
Very good. So that would be probably the most common, at least in your careers. It would be a metabolic reason for lowering that bicarbonate. But don't forget the other two.
You have a respiratory acidosis.
Yes, it could be. And we divide that. That's right. So very good. So it's either a metabolic acidosis or, less common in our patient population, an acute or chronic respiratory alkalosis. Okay, that lowers the bicarbonate. Respiratory acidosis raises it. So it's one of those three. And again, it's the same thinking. To distinguish the three, we now go into our delta analysis, and we compare the PCO2. We don't look at the pH. We compare the PCO2 and the bicarbonate to what an average person would have, unless you have previous numbers. You look at that, and it's a male, so we use
40.
Yeah,
and the bicarbonate would be 35.
No, 25.
Sorry, 25. That's what I meant. So 20. This is a difference of 11 on the bicarbonate side, and then of 12 on the.
So almost equal.
1-to-1. It's not quite 10-7.
So which of the three has an almost 1-to-1 delta?
This has got to be a. Is it a respiratory acidosis with the metabolic No, metabolic acidosis with a respiratory alkalosis.
Okay, so you're right that it's metabolic acidosis, but if the changes are 1-to-1, you don't call the PCO2 change a respiratory alkalosis because
Sensation.
it's expected to be 1-to-1. Yes, when you tell another human brain that there's respiratory alkalosis, you're sort of the byline is they have an abnormality. They have a pathologic pathology affecting their ventilation. That's why historically people shunned using the term respiratory alkalosis with the appropriate physiologic human response, which implies normality. So that's why they got away. It used to be some people called it secondary respiratory alkalosis, but the point is that when you do that, you're implying medical pathology. And so that term was gotten away from, and the word compensation evolved, which implies just a normal ventilatory response. There's nothing wrong with the person's lung, nothing wrong with their brain. Now, if it wasn't approximately 1-to-1, then you would use the word respiratory acid-base disorder. If it's above 28, then this patient would also have a respiratory acidosis. And if it's below 28, the patient would have a respiratory alkalosis. But 28, you do not use you don't use the term respiratory. And that's confusing to a lot of people because they see the drop in the PCO2 and they say, well, shouldn't I also call that a respiratory alkalosis? But the key concept is when you do that, you're implying abnormality. And so people got away from that and only use the acid-base respiratory terms when it's not what you expect from the rule. So yes, this is a metabolic, the only one of the three that it fits is a compensated metabolic acidosis, and that's what you would write on your exam if that was one of the choices. Again, we don't need to look at the pH because if you plug the 28 and 14 into the Henderson-Hasselbalch equation, you're going to get 7.32. Plus, if you look at 7.32, you're never going to be able to determine whether it's appropriately compensated. You might say, yeah, the patient probably has a metabolic acidosis. Yeah, but you know that anyway from looking at the delta deltas. The only delta deltas that approximate 1-to-1 fit a metabolic acidosis. So it's just not needed. Plus, you're using extra neurons to go in circular ways that are just going to waste your time. You want to go the quickest way to achieve the prize. And so the delta deltas are just very efficient. Ready? Let's continue. So can everybody hear me?
Yes.
Okay,
I can hear you.
great. Okay, so let's continue. That was great, Ramon.
Could I ask you?
So we'll continue now because when you have a metabolic acidosis and it's compensated in the real world and also on the exam, you have to subdivide that further into what?
Non-gap and gap.
That's right. So one major group doesn't have an elevation of the anion gap, and the second group does have an elevation of the anion gap. And so what's the anion gap in this patient?
Anion gap in this patient.
Before you do that, one thing that does come up, not so much unless you think about it more deeply, but the question is what to use the bicarbonate from the blood gas or the total CO2 from the chemistries. And there's no answer to that. They're usually one different. Remember, the total CO2 includes bicarbonate. It's always about one higher, but either is fine. Some people use one, some people use the other. Technically, you should use the bicarbonate from the blood gas because the total CO2 includes the dissolved carbon dioxide, which is not charged. So you really should not be using that extra 1 or 2 millimoles per liter of an uncharged substance. But it doesn't matter, just bringing that up. So what do you get here?
The gap here is either 14 or 15, but you end up getting 11 or 12 for the gap.
Okay, so is that normal or increased?
that's increased?
Okay, well, that's a subtle question too. They could ask you that because it depends on the type of machine in the hospital and it's hospital dependent. So
Mm.
remember, there's no universal, there should be a universal anion gap if you take a population of people. But the problem is that different machines measure the chloride differently. And so I remember we used to have at the VA hospital, the chlorides were always, because of the machine they were using, about 4 or 5 milliequivalents per liter higher than here. So the normal anion gap there was like, 8, 9, something like that. But if you look at a population, I mean, there are papers written. It's usually about 11, 12. So that would be considered normal. But you must know that, or else you can misdiagnose. But again, there's certain autoanalyzers where the normal anion gap is 8, and then 12 is high. So always know when you get to a hospital, when you graduate, and including our hospital, always find out from the chemistry lab what is the normal anion gap, and don't go by the slips or what it shows in the EMR, because those are huge ranges, and the ranges of anything are usually useless. The anion gap, it has a much tighter range, as does bicarbonate. You look at the range for bicarbonate. I don't know what it says, but it's enormous. It's nothing like that in the real world. Your bicarbonate is held to the decimal point if I measured it very accurately from day to day. It's not these huge ranges that you would get from that you would get from your impression from the clinical lab. So this patient has a normal anion gap with a compensated metabolic acidosis, but what's the problem here?
So I was going to ask, is because of the given IV saline situation?
Yes, what would you expect it to be in someone who's diabetic with a glucose of 800?
You'd expect it to be elevated.
Yes. So keep going.
Or I
Why is
getting
it not
a
elevated?
saline. I was saying, do you get a chloride load from the IV saline?
Well, chloride loads won't raise I mean, you're getting a sodium load too.
Fair enough.
So they both go up in proportion. You're not going to change conceptually, you're not going to change one without, you shouldn't change one without changing the other. Usually when you have dehydration or you give too much
Oh,
water, they both decrease or they both increase. But here you're increasing the chloride specifically.
I
But
guess
more
you do like
importantly,
translocation from the glucose, right?
well, the glucose would affect the chloride and the sodium.
Okay. Then I don't know.
Okay, so the reason is this slide. Remember that the anion gap concentration is not just determined by the input. There's an output of organic anions, and that's totally due to the kidney. And if from time zero with lactic acidosis or ketoacidosis or whatever the source of the anions, the kidney is getting rid of them, your anion gap's never going to go up. Remember, when you have a organic acidosis, you have 2 separate substances coming in at equal rates. A proton, which causes the metabolic acidosis, unless of course your kidney revved up its new bicarbonate generation from time zero to match it. Even with the proton load, your bicarb wouldn't change. So the major teaching point from this case is, don't, for the rest of your career, only think of inputs. These things aren't just going into a box. There's an output from the box that also affects the concentrations that you measure in your patients. And it's very important with the anion gap to rid your mind of the thought that it's only due to the input side. The anion gap is equally dependent on what comes out in the urine. And in the extreme case, if those anions come out from the minute they started being produced at an equal rate to what's coming in, your anion gap is going to stay normal, and but you have a proton load that exceeds the ability to make new bicarbonate by the kidneys, so you'll get your metabolic acidosis, but it will always be non-anion gap, because this will never go up. Now, the question then is, when does this occur? It occurs when the kidney's GFR is horrible. It occurs when you get pre-renal failure, or if it's a chronic issue, it can be when you have CKD or ESRD. Those anion gaps are going to go up for the same load. If you have AKI or CKD or ESRD for the same exact input of anions and ketoacidosis, those patients are going to have a higher anion gap. It has nothing to do with this load being more. It's a very important concept because 99% of docs think the organic anion load or input was greater. It's not. It's just that the output was impaired. And so it can occur for intrinsic reasons, or it can occur because, as you were alluding to, the patient got saline, but what the saline did is improve the GFR. There's no pre-renal failure here. There's no dysnatremia. This patient is volume replete. And in the absence of volume depletion, either from the vomiting or from the osmotic diuresis, you're going to be able to excrete all the ketones that come in. And so that's why there's no anion gap metabolic acidosis here. Now, there may have been before the saline, and you can sometimes see that. The patient will come in pre-renal failure, dysnatremia, vomiting, osmotic diuresis causing the volume depletion, elevated anion gap, and then you start giving saline, and you start seeing the anion gap go down, and your brain thinks, oh, I'm correcting the ketoacidosis, and that's just not true. If that was the case, the bicarb would start going back up. If you see the bicarb staying the same, but the anion gap's going down, and in the extreme case, right back to normal, all you're doing is dumping anions in the urine. You're not doing anything to the production of ketone bodies. So that's what occurred in this patient. The ketoacidosis is still rip-roaring, but the kidney's dumping all the organic. And you'd find, if you measure the urine, that's where you'd find the beta-hydroxybutyrate and the acetoacetate. So this is definitely something that is seen clinically that people just don't think about clearly. And you can make the wrong clinical decisions in your patients. You have to distinguish continuation of the ketoacidosis with dumping of the organic anions from the anion gap going away because the ketoacidosis production is getting better. If that was the case, the bicarbonate would start going up. So you have this uncoupling of the continuation of the metabolic acidosis with the amelioration of the anion gap. So it's a very interesting clinical situation. So it brings up the question, what should we call the acid-base disorder? And people have come up with this approach. They talk about what the blood chemistry picture or snapshot is and what the cause of the metabolic acidosis was, and they distinguish the two. So yes, the blood chemistry picture is of a non-gap metabolic acidosis, but that's not the acid-base diagnosis if you're looking for causation. That's the concept here. The cause of the acid-base disorder is an anion gap metabolic acidosis. The blood chemistry shows a non-anion gap metabolic acidosis. So please remember this for the rest of your careers, and it's compensated. The actual change that you would expect from the rule is 1.2 to 1. And this case was that, but it approximates 1 to 1. You don't need to think of the Winters formula. It's not going to get you any additional information. Okay, very good. Let's go to the next case. Apurva, you want to take this one?
Sure. Yeah. So this is a 18-year-old male who's and the metabolic panel is fairly unremarkable. There's no electrolyte disturbances. The bicarbonate level is a little bit, I guess, on the low side of normal.
Okay, so what are the 3 acid-base disorders that will do that?
Right. So metabolic acidosis and acute and chronic respiratory alkalosis.
Correct. So which of the 3 is it?
So I would say an acute respiratory alkalosis.
Yes, that's correct, because in acute respiratory alkalosis, for every 10 fall in the PCO2, the bicarb falls by 2. So the PCO2 fell by
roughly 30.
Yes, and the bicarb fell by 4. So
Right.
there's no other None of the other two acid-base disorders that you mentioned will give you that delta-delta. So yes, so this patient has an acute respiratory alkalosis, which you get in white coat syndromes. You get just from coming to the doctor, even if they're not wearing a white coat. So acute hyperventilation will drop the bicarbonate. And this can occur in minutes. And it has nothing to do with any organs. It's a shift of the bicarbonate buffer reaction. Now, there's two other things that occur in it that, independent of the acid base numbers, tell you that it was acute. And one of them is the phosphorus, and the other is the anion gap elevation. There's two other epiphenomena that you should remember for the rest of your life that occur in acute respiratory alkalosis. And that is, one, you get hypophosphatemia. It's a great way to lower the phosphorus. Just start hyperventilating acutely and measure someone's phosphorus. You can drop it very low. And the second thing that happens is your anion gap goes up. So I thought I would, and it doesn't go up a lot, but it goes up a little bit, and it fools the less astute clinicians into thinking there's an additional anion gap metabolic acidosis when there isn't one. So there's two questions. One that I'll talk about next. Why do you get hypophosphatemia, and why does your anion gap go up? Specifically in acute respiratory alkalosis. So it's sort of a nice thing, because in addition to the acid-base rule, we have something else that's confirmatory that you don't get in the other two causes of a drop in bicarbonate. You don't get in metabolic acidosis. You don't get in chronic respiratory alkalosis. The phosphorus going down and the anion gap going up a little bit. So yes, you're right. This is acute respiratory alkalosis because the deltas were a 2 to 10 pattern, and it's the only one of the three. So first, why does the anion gap go up? Well, the first thing is, remember that any change in pH affects the protonation of albumin. It's a buffer, not just a protein. It's one of the buffers in our blood. And it's protonated or deprotonated depending on the pH of blood. So if you raise the pH of blood, such as in this patient, from 7.4 to 7.5, you're going to deprotonate albumin. It's going to release protons, and that will then charge the albumin more than it was before, and your anion gap will go up, not because you change the albumin concentration, but because you change the charge on the same amount of albumin you had before. And in fact, you can just dial in the pH to a whole dose responsive blood pHs from any acid-base disorder. Doesn't matter. If the pH changes, you're going to affect the charge on albumin. And when you alkalinize the blood, you increase it, so your anion gap goes up. When you acidify the blood, you decrease it, and so the charge lessens. So in a metabolic acidosis from diarrhea or ketoacidosis, you're actually losing some of the charge on albumin and decreasing the anion gap a little bit. So the bottom line is there's always a change in the anion gap with every acid-base disorder, and people don't think about it. But it's so small that it's not really thought of. But you should get into the habit of thinking, what is the albumin charge doing in my patient, no matter what the acid-base disorder is? Now, of course, if you have a low albumin, such as in a cirrhotic, that's definitely going to affect the anion gap, because the total amount of albumin is changing. Here we're talking about the same amount of albumin, but the charge changing. But the anion gap, if you're asked on the exam, does the anion gap change in every acid-base disorder? Your answer, the detailed answer would be yes, as long as the pH changes. So whenever the pH changes, as a simple thought, you're changing the anion gap. And that makes it obviously a little more complicated, because we tend to think of the anion gap only changing as a resident and medical student when you have metabolic acidosis of certain types. But that's not a completely correct answer based on what I was just saying. So that's one reason the anion gap is going up in our patient. The second reason is a reason that's also coupled to why the phosphorus is dropping. Whenever you alkalinize the inside of cells, you stimulate phosphofructokinase in glycolysis. It's a very pH sensitive enzyme. It's shown here, proton affecting it. This has been known for, oh, I don't know, since the 1970s. So PFK is one of the rate limiting enzymes in glycolysis, is extremely pH sensitive. So anything raising the pH intracellularly will stimulate glycolysis. So glucose in our patient is going into the cells, but we're not just making lactic acid. It only goes to pyruvate here, but we're not only making lactic acid, which is the second contributor of why the anion gap goes up in specifically acute respiratory alkalosis. Remember, the albumin is true for every acid-base disorder where the pH changes. Here we're talking about when the pH of the cells goes up. The pH of the cells, by the way, goes up more in acute respiratory alkalosis because the carbon dioxide is so permeable. When you change the bicarbonate outside from diarrhea or whatever, the intracellular pH it changes, but it's not matching it 1-to-1. When you change the PCO2 with respiratory acid-base disorders, the inside PCO2 also drops to the same extent. It's very permeable to cell. And so acute respiratory acidosis or alkalosis has a significant effect on intracellular pH also. And it's the elevation of intracellular pH with acute respiratory alkalosis that stimulates the PFK. Glycolysis is stimulated, glucose comes into the cell, a little bit of lactic acid is made. Now, the reason the phosphorus is dropped is you're attaching phosphate groups in a lot of these reactions here to glucose. And so you get this flood of phosphorus entering the cell to phosphorylate all the glycolytic intermediates. And that's why the extracellular phosphorus falls so acutely. So just by the next couple of minutes, if you want to hyperventilate, you're creating lactic acid, you're raising your anion gap, and you're dropping your serum phosphorus. So remember that, because these are clinical clues that if you ignore them, you're not going to pick up, not only on the exam, but it'll help you with patients, because oftentimes you don't know how long the respiratory alkalosis has been going on. Now, why does it help you? It's because when you develop the chronic respiratory alkalosis, remember, initially the bicarb is relatively normal. It's a 2 to 10 change. Let's go back. But if you keep the PCO2 down at 20 for more than 3 to 5 days, well, it's during the 3 to 5 days too, but you reach a new steady state after a number of days, the bicarbonate's going to keep falling. And it'll fall a full 10 from its original level. It's going to fall another 6 beyond the acute fall here, once you've reached sort of so-called chronicity. But what that does is it returns the pH back almost close to normal. So initially you have this fall in the PCO2, a modest fall in the bicarbonate, that's your pH. You keep this at 20, and this keeps falling until you reach the chronic steady state. You do the math, the pH is going to be around 7.4. Well, when that occurs, the intracellular pH isn't as low, and so the glycolysis, as the days go on, from that initial stimulation, comes right back to normal. So the intracellular pH is not high like it was initially, and glycolysis is shut off, as is your deprotonation of albumin is dynamic too. As that pH outside continually gets closer to 7.4 over the next 3 to 4 days as the bicarbonate falls, this reaction returns to its original level also. So these things here that we see in our patient are really only in the acute phase. And that's why these are very helpful clues that we have temporally, in addition to the acid-base rule that we talked about, we have an acute respiratory alkalosis. Okay, so this is a very interesting case. Okay, let's do one more because of the time. And I'll take this one. So we have a 60-year-old male. And again, I'm ignoring all these numbers. I'll focus on the acid base. I zero in on the bicarbonate. I close my eyes to all these other numbers, and the bicarb is up 36. Again, what are the 3 causes? It's either a metabolic alkalosis or acute or chronic respiratory acidosis. To distinguish the 3, I look at the delta bicarbonate from normal. It's a male, so I'll pick 25. And I'll look at the delta PCO2 from 40, which would be the normal number. So the PCO2 is changed by 32. The bicarb's changed by about 10. The only acid-base disorder of the three would be chronic respiratory acidosis. Okay, the PO2 here, I look at whenever you have someone with an elevated PCO2 or just a drop in the PO2 per se, whether the PCO2 is normal or not, actually, always calculate the A gradient because you want to distinguish the cause of hypoxia. Don't just look at the PO2 and predict what the reason is. If the A gradient is normal, you're not going to find likely a problem. It means the ventilation is normal, right? Because the PO2 can be low either because the PO2 in your alveoli is low, in which case you know the PCO2 must have gone up, because remember they're roughly additive, not exactly, but when the PCO2 goes from 40 to 72, the PO2 in your alveoli drops, and you can actually calculate what it is, and this is how you calculate it. On room air, it would be 150. That's the partial pressure of oxygen in room air. It would be 150 minus 5/4 of what the PCO2 is the oxygen in your alveoli. So you're only starting off with a PO2 in your alveoli of 60 something. Just because you can't have a PO2 any higher when the PCO2 is 72. Okay, so that's what you're starting with. So then you take that and you subtract that from what the blood is, and if the answer is 10 or around that, you know that the lungs are normal. There's no VQ abnormality. There's no pneumonia. There's nothing going on in the lungs. You're not going to have emphysema. You're not going to see anything, fibrosis, nothing. You have a normal transfer of oxygen from the alveoli to your blood. That's what a normal A gradient means. So the hypoxia here is not due to anything going on in the lung parenchyma. It's due to the fact that you're starting off with a PO2 that's too low in the alveoli. So it's very pleasing conceptually to think of it this way, because if the A gradient is elevated, that's when you know you have something going on in the lung. And the nice thing is you don't have to do a chest X-ray to figure this out. You could figure it out just from these numbers, just like, as I was saying, you can tell the cause of diarrhea without scoping the patient or doing anything fancy, just by looking at the acid-base numbers. If it's metabolic alkalosis, you know the diarrhea is coming from the colon. If it's metabolic acidosis, you know it's coming from the small intestine. And, you can impress a lot of people doing that. Okay, so again, it fits chronic respiratory acidosis because with the numbers we had, this was the proportion of the changes when you do the math. Okay, I think we'll stop at that one for today. Does anybody have any questions or anything that wasn't clear? Okay, everybody. Thanks for joining, and thanks for participating. I know it's not easy being put on the spot, but you guys did great.